if I could ask you to introduce yourself, Dr. Wong.
I work at Beaumont. I think you guys know that. I've been here for about 5 years. I was at Henry Ford before, so I've been doing this for a while, many years. All I mainly see at Beaumont is low vision, or traumatic brain injury, concussion, stroke, things like that. So I see all different types of eye diseases that will cause people to lose their vision. It could be, something that's gradual or something that's, very fast or overnight type of vision loss. We usually start with, an ocular history, what happened, who are the doctors you're seeing, what medications are you on, what are the things you're having problems with, is it reading, is it seeing far, is it driving, what functional tasks are affected by your vision loss. And also, what current devices are you using now? Do you use electronic devices? That's a big thing now. Thank goodness for technology, at least in that area, has really opened up a lot for these folks that have vision loss, including software for computers. We just recently obtained the Orcom 2 and the Orcom Smart Reader, I believe it's called. So we're still playing around with that one. So anyways, getting back to the exam, just, finding out what they're using to help them function better at work, if they're still working, or in school, if they're younger, what they're doing, if they're at home, if they're older, what do they do with their free time? What do they enjoy doing? Activities of daily living. Are they having trouble with, functioning at home, taking care of themselves? Who are they living with? Do they have a good support system? Do they have access to rides? So this is all the information we kind of take kind of in the beginning to find out, what they are using, what areas they need help with, and what their support system's like. So I normally start with that. I also watch how a patient will walk into the room, who's with them, obviously. You're going to find that out eventually. If they come in with a walker or a cane, and you have to assess if their mobility, if what they're doing is safe. And then we will, discuss again their symptoms. And then, of course, I always will try a refraction, make sure, check the glasses that they are wearing, and compare it and see if I can improve upon it and make sure it's a functional improvement. We don't want them wasting money on glasses that will not improve their visual function. If there's, a 2-line improvement and I will trial frame the glasses and the patients feel like it's better, definitely go ahead and give it to them. Trial framing, a new reading prescription to see if they are better for them. And I guess we always think about reading that it would be normal reading, right? Like 1 imprint or 0.8 imprint. But sometimes, you can prescribe reading glasses for someone that's going to read like large print, just larger print material, like a large print Reader's Digest. I have patients that use large print books. I have patients that read on a Kindle or an iPad. Sorry about that. Kindle or an iPad, depending on their age. But then again, I can have some 60-year-olds that use no computers at all. And then I can have a 95-year-old that's like on the computer, using things that you wouldn't ordinarily think, maybe not 95, maybe 90. But they can surprise you that way. So good refraction, always start with that to see if we can make things better. And then I will usually take a look, do confrontational fields, make sure that, there's no visual field loss peripherally that would impede their mobility. That is especially important with strokes, with left or right hemianopias, bumping into the left or right side, depending on where their deficit is. And then I will take a look at their eye health. I usually don't dilate my patients unless they don't see anyone but me. In other words, not a non-progressive disease. So just to get a look, I like to know what I'm looking at, to kind of understand what function I think I may get after maybe I look at a macula or an optic nerve or or their cornea. So usually after that, we get that kind of information, we find out what they want to work on, and we usually go into a different room and we work on function then. So, and usually that's rating, but it can be, seeing the TV a little better, or, again, like activities of daily living. We have an independent living aids catalog here that we give to many people to kind of look at on their own, to decide like if there's anything in that magazine that may help them function better in their homes, which is very important to keep these people as independent as long as they can remain independent. It's important to them. And then we'll go over goals. What is their goal? And we can't always attain their goals, but we try at some level to get them reading, at some level, at least to gather information that they need to know, like checking their bills or writing out checks or managing things for themselves, for their household, if they don't have help. So, basically, it's a goal-driven kind of functional exam. What do you want to do, and how we can help them do it better or easier. Lighting is important. Selective filter evaluation can be important. Decreased contrast sensitivity is pretty big. It's almost as big as visual, the Snellen line loss, right? So you have 2200. You could even have somebody that has 20/50 vision but has optic atrophy and their contrast is horrible. So that can be a bigger deficit than 2100 with no contrast loss. So then we want to make
Dr.
sure.
Wong,
Yeah,
I'm sorry. Can I back up just one step?
you can do whatever you want.
I'm sorry. Is there a line of demarcation that says I have low vision, or, I should be concerned? So from, a medical standpoint, is there a line that defines low vision? Is there a condition that defines low vision? So it sounds like there are many factors involved in it, but is there a point at which a person says, I should, when you're getting your eye exam, that a person maybe says, I should get help because, now I clinically have low vision?
I think that's a really, really good question. I feel that if patients are around 2040, 2050, and they have a progressive disease, that's a great time to get in and get started and get like used to some of the things that they may not need now, but they possibly could use in the future. So when you have more vision, you're more apt to learn how to use magnifiers than when when it gets even worse. And then, we could do other things as well too. So I would say around 2050 is when I start getting my referrals from retina or glaucoma or cornea specialists, things like that.
Okay, you mentioned progressive. So are there people who just kind of stay in that 2040, 2050 range? Or if you are 2040, 2050 and progressive, is there an expectation that, your vision is going to continue to deteriorate?
Yeah,
Or
I
does
guess
that
that would
depend on the
depend.
condition?
It would depend on the condition. Like, let's say somebody with the beginning of like, dry macular degeneration is slower than wet macular degeneration. Or you see somebody like I saw a young man yesterday with Usher's disease. So he's signing and he has, like less than 8 degrees of field. He's 22. It's a time. And we have I'm just one small piece of the vision rehabilitation, like group of folks that help these people. Right. So he's learning to read Braille, because there's a good chance if he has less than 8 degrees of field and his central vision is starting to become involved at the age of 23, that he may lose his vision. So, there's the planning. Okay. So that's one extreme level. But let's see if it's somebody that's 20, 50, and they're thinking, and it's not going to change. Like, let's say they've had a history of optic, atrophy, or for whatever reason, and it's not going to change because it's from birth. So 2050, they still may have some problems, right? They still may have, problems with contrast, or they may be 2050, 2060, and they want to drive, and it's kind of iffy. So even at that level, you want them to be able to function to the best of their ability, if that's going to be their vision for the rest of their lives. And I know 2050 may sound great. 2050 is what you need in one eye to drive. So legally. So, I guess, like you said, it depends on the person, depends on the disease and the progression. Is it stable? Is it progressive? What does it look like it's going to do?
Talk to me a little bit about degree of field. What is
Okay.
that for those who may not know, and how does that impact your overall vision?
So normally in each eye, horizontally, we have 130 degrees of visual field horizontally, and about 100 degrees, I don't know, I should know this exactly, vertically. So in order to be able to drive legally, you need at least 110 degrees of horizontal field. But if the clinician decides that at 90 or 100 degrees of horizontal field, and that would be like kind of uninterrupted horizontal field. In other words, they can't have a bunch of absolute scotomas in that 100-degree field. They have to have just 100 degrees. We can decide that, yes, they can still be eligible for driving with driver's rehabilitation training to learn how to, work around whatever deficit there is with a licensed trainer at Beaumont or A&A driving or whatever we pick. So visual field's important. If you have a disease like macular degeneration, which is very common, you're going to have central visual field loss. So you'll still be able to have your peripheral field. So you'll have your, what we call traveling vision, walking around vision. That's very important for, ADLs and getting around. And that's why sometimes family members of patients with macular degeneration will be like, you're legally blind, but you just picked up that piece of lint off the carpet, right? That's because in the peripheral field, they found it and they saw it and they can find it and pick it up. Maybe not lint, but whatever on the carpet. So they can, I don't know if you guys know this, but they can kind of like eccentrically view around their central absolute or relative scotoma and kind of, look around. So if in other diseases like retinitis pigmentosa, you're going to have or different retinal dystrophies, there's tons of them. You can have what these folks will notice first is like their vision's really difficult at nighttime. They'll be outside, like kids or like young teens or whatever. They'll be like, God, like they're literally night blind. Like, I don't know where I am. Like, I'm totally lost when it's dark. So that usually indicates that we have a rod dystrophy, right? Some type of rod, rods and cones and are in one of the 10 layers of the retina. And the rods are not working, and rods are for scotopic vision or nighttime vision. So that's where they're going to lose their vision is nighttime. And then eventually after that happens, they will start losing function of the rods and cones that will show up in a visual field. So it progresses. The pathogenesis of the disease gets worse to where their visual field starts to get constricted, but slowly. In usually most of the retinal dystrophies, it's slowly. So at least in that sense, they have time to learn how to scan. And that's why sometimes when you meet people with retinitis pigmentosa with like less than 20 degrees of field, which would consider them legally blind, even if they're 20/20 vision, and we can go over that again. You will not even know they're visually impaired because they have had so many years of learning how to scan that they can scan a room with a 10-degree field and you'll have no idea they're visually impaired because they're that good at scanning, because it's been slow and they've had time to train. their brain and their eyes, and how am I going to function in this world with this degree of field? I'm going to scan really fast, and you can't even tell. So visual field's very important, as you can tell, to get around. And don't get me wrong, retinitis pigmentosa patients or other retinal dystrophies, cone dystrophy with rod involvement, or like Stargardt's is another genetic one. Cone dystrophy. What am I thinking? I can't think of it right now. Anyways, a bunch of them that either affect the rods first or the cones first. So cone dystrophy will obviously, you usually have a large central scotoma, and it's usually absolute. Like, in other words, a relative scotoma means that there is an area in their field that is affected, but they can kind of see through it. That's a relative scotoma. An absolute scotoma is a scotoma that is completely like there's no vision in it. So when we look at a visual field, it will be completely like darkened out on the Goldman field. But a relative scotoma will have kind of like hashtag marks, not hashtag, but like hash marks saying that this patient has a scotoma, but it's a relative scotoma. So I hope that answers your question with visual field.
It does, and it leads me to another question. At what point, if I'm seeing my regular ophthalmologist, do I determine that maybe I see another type of doctor? What separates your specialty from, my regular annual exam with my ophthalmologist for my high level of stigmatism kind of thing?
So I think the two exams are very different. I do see healthy patients on occasion, and that's just we're trying to get the best static acuity we can. They're not having any problems with function. They just need glasses to see better, to get that pinpoint of light on the retina, right? If it's in front, if it's in back, if it's like in front and back with astigmatism, we just want to get that light to bend through the lenses we give them, whether they be contact lenses or spectacle lenses, so we can bend the light to get the clear image on the macula or the retina. Macula is obviously central vision. So I don't know if I answer that question correctly, but there's a huge difference between seeing, getting a regular general eye exam by your general optometrist or ophthalmologist than having a low vision exam. Low vision is all about function.
Okay, so is there a point at which, if a patient has not been referred, because sometimes people will go to their doctor and they know perhaps that their vision is deteriorating, or that they have, cataracts or glaucoma or something else. And they, maybe their current practitioner doesn't refer them elsewhere. So they
Right.
may not know that additional resources are available. So at what point might you suggest that someone self-refer? Like, at what point should a person be kind of concerned that maybe they need to see someone who has a little more specialization in their loss of
Yeah, like that's kind of a fuzzy area, right? Like, 'cause a lot of
yeah.
ophthalmology is usually most of my referrals. So I don't get a lot of referrals from optometry like me, because they're usually going to see healthy people. I do get some, but most of my referrals will be from doctors that know there's something going on, like retina, cornea, glaucoma, uveal specialists, things like that. Some of these people will fall through the cracks, and I think those are the people you're talking about that maybe have mildly diminished vision or moderately diminished vision, but are still like legal to drive, right? Like they still get around, but they still may be having some functional difficulties.
Right.
Hopefully they would, like, with the world at our fingertips with, computers or iPhones or whatever, they could look up, what do you do when you have like, decreased vision for this or that or whatever, the other. And usually, low vision rehabilitation will pop up, and maybe they can just, say, hey, maybe I'll go see this doctor. There is some hesitancy with patients that are referred to low vision, because it kind of feels kind of depressing, right, for them. So I'll have some patients that, I see a lot of people from retina that just come in and they're like, man, I knew it was like bad when they referred me here, like this is like my last stop. And that's not necessarily true. They could still be undergoing, treatment with their ophthalmologist, the specialist. But I do feel there's a little bit of kind of like, oh man. And then there's also people that are like really happy to be here and get help. So it all depends on what stage of, grief from the loss that the patients are in. And if they, in that group of people that you're talking about, that are kind of like, I wish I could see a little bit better, but the doctor's not too concerned, but I'm having kind of some problems. They may look up and say, low vision, like that seems like pretty serious. So maybe I don't need that. So I could see where, some people could fall through the cracks. So hopefully, they're going to be looking for information if they feel like they have a deficit. Hopefully some of these doctors, I think they will say, you're not really quite legal to drive anymore, because that's what you're going to find on like general exams that people don't even know, like sometimes because they don't, cover one eye or the other or check it out, or they just feel like they're still great to drive, with 2100 vision. And they, will be told and be like, wait a minute, and I personally do not go after people's, not like that's not the right way to say it. I usually don't like contact the DMV or something unless it's really, really, really bad. But I have honestly never contacted the DMV to take someone's license away because that can get pretty dicey. I don't know how I got in the subject, but anywho, hopefully the people that are kind of in the middle there somewhere, not that don't have somebody that are referring them, will find help on their own with all the information that's available to us.
Yeah, I think, I'm certainly sitting here thinking about how we can help bring more awareness to something like low vision, because I feel like, I've had aging parents, and my father actually had Parkinson's, and I can remember that as the symptoms were coming on, he just kept putting it off to, I'm getting old, like, what do you expect, baby girl? I'm getting old. So, and we were concerned that maybe there was something else going on, which eventually we did find out there was something else. So I feel like vision would absolutely be one of those things where people would say, I'm getting a little bit older. I've been wearing glasses most of my life. So yeah, this just comes with the territory kind of thing. And so, I'm wondering how we can help people be more aware that this might not be, a natural occurrence, or there may be something that they can do to turn the corner and help improve their function. Like, it's not an inevitable piece for people. And I'm not sure how we help people learn that there is a
Right.
thing called low vision, and maybe it's not the end of the world, to your point.
Yeah. Well, it's totally not the end of the world. I mean, but I'm sitting on the other side of the office. So, I can't really say what that would feel like. Right.
Right.
But Parkinson's can be brutal because, you can have a lot of double vision. I see people with double vision almost every day. So we definitely got to get people out of double vision. You know, and Parkinson folks are going to have trouble with eye movements. They're going to have flexure, extension in the way they walk. We can use yoke prisms to fix that too. So there's a lot of things we can do to make people a little bit more comfortable. I'm hoping that, and I have noticed that, like with my neuro piece that I've been doing here. So I'm like two optometrists. Well, it's me and Dr. Nielsen, and the rest of the doctors at Beaumont, like the entire hospital system, are like MDs, right? So they're like, what do you do? Why are you here? I'm kidding. But you know what I mean? Like, what
I
are you
get
guys
it.
doing here? You guys aren't medical doctors. And we're like, just minding our own business, not getting paid as much as you, so you shouldn't even worry about us. Okay. And just kidding. But anyway, what's really cool is like the neuro piece that I do. Like I have like neurologists sending me people now. Like I'm on their list of like referrals. Like that's awesome, right? So that a lot of people that had strokes in the past, like even 15 years ago, were like sent home with like a left homonymous hemianopia with visual spatial neglect. They're like, oh, well, that's just the way it is. Or they didn't even know it was there. So now what's changed for me is like these neurologists are like, you know what? I want you to go see, Jennifer Wong OD, right? Because you have even if you don't feel you have any vision problems right now, I still want you to have her check it out. Or yes, you do have vision problems. You have a right hemianopia, or you have other problems, visual processing issues, and I definitely want you to see her. So that's how we get, like, I know that's neuro, but that's important to get a referral from the doctor. So maybe if we look at low vision from a primary care standpoint, like if you look at a list of, someone's HPI, history of present illness, a lot of times it'll just say vision loss on there, right? So somewhere along the line, these patients told their primary care physician, like, yeah, I have a little bit of macular degeneration, or I have glaucoma or whatever. And maybe, I don't know how many, primary care physicians are so busy and overworked, how many of them will say, like, well, how's your vision? Like, is it bothering you? Like, I don't know. Maybe, I mean, we're not giving that many talks and stuff lately because of COVID, just talking to like an audience of like PCPs. And believe me, I don't really like public speaking, but, I'm willing to do it, I guess. I mean, I have done it. Just to educate them on, like if your patients have vision problems, there's people that can help you or help your patients, function a little better.
It is interesting that you bring up that point about the neuro, and you mentioned double vision. I used to work at the Heart Association, so stroke was May is American Stroke Month, as well
Oh
as
man.
Vision Month. And I think, I know of someone who, kind of post-stroke had some vision issues, and it's just kind of like, well, that's, probably a result of the stroke, is usually how the conversation goes.
Right.
At the doctor's office. And now you've got me thinking,
Oh
maybe I should
no,
have
there's
this
so much
person
we can
called
do.
Dr. Wong.
No,
Yeah.
there's so much we can do. Like, like what do? I do, refraction. There's always prism needed. Almost always. There's almost always an exophoria. And then I have patients, it all depends on where the stroke is, right? If it's in the pons, then you're going to have like a cranial nerve palsy. They're going to come in with one of their eyes patched because they have that bad of double vision, right? We could put prism on there, like in the form of Fresnel press-on prism, to at least get them binocular. Most of the time, I've had a couple people, I just can't do it if it's like oblique double vision. And then, then they could have other problems like ocular motor problems. That's huge. Ocular motor function is everything. And I know we're kind of veering off the basic low vision thing. But, like you have decreased saccades, pursuits, fixation. So that's going to affect your entire life, because a fixation is when you're looking at your finger to take out a sliver. So your eyes cannot fixate. In other words, the image on the fovea or the macula is not stable. Wow, that must be really hard. I can't even imagine. Pursuits, like following a tennis match, you can't do it. You're either have trouble engaging or disengaging your eyes from following the match, of the tennis match. Saccadic deficiency is probably the number one thing we see because it's located all over the brain, especially vertical saccades. So if you can't, saccades is moving your eyes quickly from, side to side to like, and then, vergence takes over and accommodation to focus on an image, but you have to be able to move your eyes with saccades to read. All reading is a series of right saccades. Your eyes move to the right, to the right, to the right. So if your saccades are not working well, you're not gonna be able to read, because that one ocular motor function is everything. So I may find hypometric saccades, in other words, catch-up saccades. Usually they're not hypometric, or I mean hypermetric. So if they're like needing two saccades to get over, that only usually would take one, then think about how much slower reading will be. Because if you were to read, you will notice, like if you go across, your eyes are just moving, constantly moving as you're reading. So if that's interrupted, reading is going to be very difficult. So then we have occupational therapists that are trained with neuro rehab that can, take what I find and say, these are the things we need to work on. And not necessarily, vision therapy. What we need to work on first is overall visual processing, ocular motor skills, and then move on to binocular problems if there indeed are binocular problems after a stroke. So I can start it, but usually it requires therapy to get the stroke patients, the traumatic brain injury patients, which includes post-concussion syndrome patients, which I think are one of the most difficult patients to help. Patients that have had a craniotomy, brain surgery, that's a traumatic brain injury, not really, directly traumatic, but it's trauma when you go in and do brain surgery from like a hemorrhage or someone falling down the stairs or just falling in general. Falling is very, very scary. Like things can happen from falls that can be very, very bad. So being that I know that because I see it every day, not necessarily from falls, but I've seen a lot of it. When I see my regular low vision folks, right, like they have macular degeneration, but if your 90-year-old lady who's like, I'm never going to use a cane ever, ever, I don't care. And she's kind of feeling around and, or holding on to one of their loved one's arms, this person probably needs a walker. So, we have to have that discussion with them about mobility and safety and talk about fall risks and what can happen from falls. People think, oh, maybe I'll break a leg and that can be, fixed. But if you hit your head and you have a hemorrhage or something like that, it can get real serious real fast. So sorry, I don't know where I got on that tangent either.
No, it's okay. This is great information. I do want to take a second to see if anybody else
on
the call has any questions. You would need to unmute yourself if you do.
Hello, I have a question.
Sure.
Yes, if a person was not in the Beaumont healthcare system and they want to come see you, do you take referrals or how does that work out? If somebody wants to come see you, but they weren't part of the Beaumont healthcare system, how can they, how do you take patients like that?
That's really no problem. I see a lot of patients that are not in the Beaumont system, and then we have something on Epic, which is called Care Everywhere. So we can usually access their charts from a lot of the, hospital systems in Michigan. A lot of times we can get imaging labs just right from Epic. So we take all insurances. I mean, I take Medicaid. It doesn't matter.
One more question is,
Sure.
Does Medicaid, I know so you have a low vision exam, so that's more extensive than a regular eye exam. Does Medicaid usually pay for low vision exams?
Oh yeah, they will, because it's medical. So then it's
Okay.
now no longer considered vision. It's considered a medical exam. So, like instead of myopia being your number one like diagnosis, it's going to be like macular degeneration, right? Or it's going to be tons of things, glaucoma. It could be optic atrophy. It could be basilar artery stroke, which by the way, you never want to have ever, or any type of, status post craniotomy. Like all those things are medical, and that will be usually my first diagnosis will be the visual impairment code is usually my first code. Like profound vision in one eye or visual field loss and things like that, and then the diagnosis after of what caused that.
Okay, thank you.
No problem.
Does anybody else have any questions, or can I just keep diving in? Okay. All right, folks are kind of quiet. So I am hearing a few things that may jog either an individual or, someone caring for someone or someone who's a coach or an ally for someone. A few things that may jog folks to say, maybe we need to consult low vision. One of those I'm hearing is the degree of field might be an indicator that, because you did mention that people may not, because they've kind of adapted, they may not realize how deep their issue is.
Maybe, but remember we have two eyes. So you have to have visual field loss in both eyes for you to really notice, because whatever field you're missing in one eye will be covered by the other eye.
Okay.
Right. So usually I would say low vision is going to be vision, like actual Snellen loss, acuity loss that people will notice more so than a visual field.
Okay. All right. Perhaps after a stroke, if there are vision issues after a stroke, it may be worth, depending on the function. Worth. Okay. You mentioned, you mentioned falls as well. Both my parents were prone to falls. So I am familiar with the many things that can happen after a fall. Are there other things that, and then I think you mentioned the 20/40, 20/50 with a progressive condition.
Right.
might be worth seeing a low vision specialist.
Yeah, like even if there's although I would say that I'm looking at my like acquired brain injury rehabilitation sheet here. And what I would ask for, or what my exam would be for a neuro patient is kind of different than low vision, if you want me to go over that.
Sure.
Okay. So neuro is a little bit different than your typical low vision, because I think it can get more multifaceted than, like, let's take our traditional low vision macular degeneration patient, which is very bad. I'm not discounting their symptoms or their vision loss at all. It can be profound vision loss, or it can stay kind of steady too. So usually it gets a little worse, but then with wet macular degeneration, we also have, injections that can stop the disease. 15 years ago, it was, catastrophic vision loss. So again, you take your typical macular degeneration patient, and we kind of know what we want to do with those folks. We kind of have an idea because we've seen so many of them. I feel like with strokes and post-concussion syndrome and traumatic brain injury, including craniotomies from, like, let's say acoustic neuroma, or, AVM malformation, you definitely would just want to get a good history again. And then the current rehabilitation that they may be in, they may already be in physical therapy from a left or a right hemiparesis. They're probably in a wheelchair if they have a hemiparesis and it's the beginning of their rehabilitation. They could have like a belt that the patient that's taking care of them, what do they call that? I forgot. Anyways, a belt that, that they use to pull the patient up and down or help them guide them into their chair. If you want to know what their current rehabilitation is, what they're involved in, they could be in speech therapy for cognitive problems. A lot of people think speech, and I kind of did too, before I really got into neuro heavily last 5 years. I always thought like speech was definitely just like for aphasia, right? Or, trouble, reading something and understanding it, and trouble like explaining to somebody what you're feeling in the form of speech, which can be very frustrating for patients. But speech therapy is, for all cognitive issues after a stroke or any type of traumatic or acquired brain injury, right? Which not acquired. Acquired would be like a stroke. Traumatic would be like a concussion. You fall, you hit your head, or it could be more serious, a moderate brain injury, like maybe getting hit in the head with something from falling, a car accident, some type of assault. So they could already be in therapy. And many times there can be cognitive issues where they, have a problem with memory, or they have a problem with long-term, short-term memory, cognitive issues, just like simple problem solving. You can actually, like, when you examine these folks, you can actually see them like thinking, like almost see them processing the information. It's just a little bit slower. You just have to give them time to kind of explain and try to explain what they're experiencing. And it can be very frustrating for them if they can't explain it. And thankfully, usually there's somebody that knows this patient really well that will explain to you what they've seen, the changes in them since this has happened. Because this is the first time you're meeting the patient, and it could be the same thing for you guys when you first meet your clients and you don't know what was this patient like before their stroke, or before their injury. Like, I don't know. And what you're going to do is you're going to rely on the patient or the person that knows them really well to kind of tell you how they're different. So again, speech therapy or the occupational therapy, which is mainly, what do occupational therapists do? They're working to help you use your body. Usually, I think it's mainly what do they call it? From like the waist up, kind of like in PTs from the waist down of therapy. So and you think of occupational therapy like in their occupation, but not necessarily. It could be at home, working on their computer, scanning to the left or right if there's visual field loss. You could be working on eyes working together. So you definitely want to make sure you know what kind of rehabilitation they're in and how it's going. Like sometimes the therapy is not going well enough because of vision problems. And, sometimes I get a lot of referrals from OTs. They're like, the speech therapy is not going very well. We're not finding any, improvement, and we're kind of plateauing. And then you come to find out that, this patient didn't have the right glasses on, or they needed binasal occlusion, or there was some other issue visual processing wise that wasn't working. So that's why they weren't able to read the speech therapy homework well enough to be able to participate in the speech therapy to help them get better. Or they're an OT and they have, like we talked about earlier, visual field loss or double vision or something, and they cannot participate in the OT because of a vision problem. So we want to fix that problem the best that we can so that they can participate in their therapies better and get better. Because with neuro stuff, there is a time limit, kind of. The first year you're going to see most of your improvements. So there is a time limit on this. If you see, sometimes I see patients, a year post stroke, and you're like, we can try to get some of this stuff better, but we kind of miss that window of opportunity of, that first year to get people better and in the right therapies and really working hard. So the patients need to be motivated because they really have to work hard in therapy. I mean, it's like a job and it can be exhausting. And that's another thing you want to watch out too with your clients is, if they're in therapies, like, are they doing too much therapy? Because you'll have these hypervigilant people that are like, like training for a marathon with their therapies, only to find out that, if you're exhausted after one therapy and your brain is healing, and it takes 2 days to recover from that therapy, that's probably too much therapy and you're not getting anything out of it. So it's this balancing act. And I'm not so much involved in that as the occupational therapist, because that's more of their role, or their physical medicine doctor, because that's usually, PMR doctors will be the doctors that are kind of overseeing all this rehabilitation. So you just want to keep an eye out for your clients to make sure that, they're not doing too much. So the next thing we're going to look for in a neuro person is any visual field loss from the opposite. Like, so if you have a right hemisphere, if it's parietal lobe, frontal lobe, temporal lobe, or occipital lobe, I hope I'm not boring you guys with this neuro stuff. It will be on the other side, right? And the same thing goes for their body. If they have a right, cerebellar infarct or problem, then it's going to affect, their balance, but it'll affect the left side more. And then there's something called visual spatial neglect. Neglect occurs mainly in the right parietal lobe. So neglect means that these patients don't even know that visual field is missing. They don't even, or not that let me restate this. They don't even know that they're not attending to that left visual field. Like, they completely ignore it. So it's very, very interesting that the brain would do that. That is pretty hard to rehabilitate, but it can be done. And then my job also is to eliminate any double vision. You got to get them out of double vision. I will ask some questions on, is their concentration the same? Do they have the same amount of attention? Like when you sit down to read a book, like when we sit down and read a book, like we could probably read for an hour, right? Some of these folks are like, oh man, I just can't do this after 10 minutes. I'm just losing my focus. I'm not interested anymore. So changes like that, and any cognitive changes they have. Are they having problems reading? Like, because with stroke can really affect reading, and in really weird ways too. Like the words will sometimes be moving. I could get into a whole discussion about visual processing that you guys would want to probably like not listen to, about visual processing and there's, two visual processes that we are relying on in the brain to give us our visual world. The brain tells the eyes what to see, vision's all brain. 50% of the brain is involved in giving us our visual world. So then also you want to ask if they have any photophobia. That's a big one in low vision and neuro. Like if they're photophobic, then we have to really control that photophobia so that they can function better. And the
What
way
is
we do that,
photophobia?
photophobia is just sensitivity to light.
Okay.
Yep. So that's a big one. So, and that can affect function in a big way. So if you have photophobia, then we can go ahead and try different, what we call selective filters. So there's certain filters that will work well with, let's say, a patient with retinitis pigmentosa, or a patient with rod cone dystrophy, or a patient with rod monochromatism. And it can get really, and it's really interesting, like whatever wavelengths of the filter that allows in and what it will do for the patient's rehabilitation. With that Usher syndrome patient I was talking about that I saw yesterday, that young man, like he picked all the ones you would think, and sometimes it doesn't work out that way. But he picked the ones that we would generally think would help that type of disease. And like cone dystrophy, like there's a certain kind of like reddish magenta color that these people love, and it works for them to see better, to function better. And then photophobia from a stroke can just be just light sensitivity, or from post-concussion syndrome. I mean, these patients sometimes come in wearing dark sunglasses, like they can't have any light around them. And eventually through low vision rehabilitation and through therapy with their occupational therapist, neuro occupational therapist, working on visual processing with yoked prisms, doing motoric tasks while seated, changing that brain and changing that image and getting the visual processes to communicate with each other. Because once they've adapted to that prismatic change, that means the visual processes have communicated. That means we have proprioception, kinesthetics, ocular, vestibular, everything working together at that moment. So that's reestablishing new pathways that have been damaged from the stroke or whatever neuro insult we're talking about. So headaches. So I don't know what type of clients. You guys probably work with a whole bunch of different clients with different symptoms. So we have to control headaches from post-stroke, post-seizure, right? Whatever, craniotomies. So headache management. That's not my department, obviously, but you want to make sure that they're being managed, because if someone has a headache every day and it's bad, it's going to be really hard to function. Are they sleeping well? Are their headaches managed? Are they getting enough rest? Very important to get better. Some of these clients, I don't know if you've ever had a client tell you this, but this is kind of an important one. And it's kind of weird because, then maybe people start wondering if it's psychiatric or some type of cognitive problem. Some of these patients will feel really overwhelmed. Like, we're like, okay, we know you've had a stroke, or we know you had a traumatic brain injury, but what's your deal? Like, why can't you go into busy environments? Why can't you go to the mall? Or why can't you go grocery shopping? Not like we would say that like in a mean way, but we'd be like, kind of scratch our heads like, really? Okay. I didn't think that would be a problem for you. But these people can be very, very overwhelmed, and it's scary for them. They're like, why can't I go shopping? I mean, all I had was a stroke. I mean, like, come on. And they can just be overwhelmed, or in our world, just over focalized. So the way I can describe this the best, and then when I tell people that are experiencing this, they're like, yes, definitely, that's it. So they will go into the store, and like we will see, an aisle of food. And what they will see, let's say we're looking down like the canned aisle, right? Like where you get all your stuff, like kidney beans and your cans of tomato sauce, or whatever. So we just look down there and we're kind of like scanning around looking. And what these people will see, instead of having like an outline to their vision or a visual structure to their vision, they will actually be so over focalized that they will actually look at down that aisle and see like every can that's every can that's there. So it's very overwhelming to them. So imagine looking down and seeing all that information. And you're like, oh my gosh, like visually, I can't handle this right now. I got to get out of here. People will literally leave the store. So we can make those things better. So, and then I don't know if any of your clients have balance problems or vestibular issues because of their eye issues, because I took a vestibular course last summer. I was the only optometrist there. And the rest were physical therapists. So it was really cool. So since a lot of my patients have dizziness, they can have BPPV, actual vertigo. Like I wanted to know what I was talking about when people will say, well, sometimes I feel kind of dizzy. Well, what is dizziness? So we have different visual tests we do that can determine if there's a vestibular part in their vision problem. And if there is, then I don't usually refer for vestibular therapy, but maybe I'll reach out to their primary care physician and say, you know what, I think this person may have maybe a vestibular problem. Maybe we should have them screened for a vestibular issue and then fix the dizziness because, again, fall risk, right? So vestibular system, there's 4 components involved. We have the eyes, the ears, and our feet, proprioception, right? That keeps us in the cerebellum that combines all this information to allow us not to be on the ground, to stand upright. So to not let gravity take over. So if you have one problem, like let's say we have vision loss, then we're going to rely way more on proprioception or our feet and our ears to keep us upright because we no longer have the vision part, right? So let's say you have a diabetic patient that has vision loss and has neuropathy in their feet. So we have 2 pieces missing. We're relying solely on the ears to keep these patients upright because they can't really feel the ground because of proprioception loss due to, neuropathy, poor perfusion of blood vessels to their extremities, and they have vision loss from diabetic retinopathy. They're probably going to have some mobility problems because the ears can't do everything. As much as the cerebellum is going to try and balance all these things. Sorry, I shouldn't use balance or get all these things to work together. Something's going to have to take over more. So these folks, if they enter vestibular rehabilitation, there's different things that the vestibular rehabilitation specialists will want to do, adaptation, habituation, all different, depending on what the problem is. And I used to know all those things, but I don't do vestibular therapy, but I can kind of figure out what they may do and to make sure that these people are not falling. So, so sorry, I didn't mean to get off on a vestibular tangent there, but it could be important for your clients with vision loss if they have any dizziness or feel off balance. And then, of course, you guys probably, when you're dealing with patients that have vision loss, they may want to drive. So that's something that we can work on together and work.
I find the way that all of these things are interrelated very fascinating, actually, because it does make you think, it does broaden your perspective of how each part impacts the other, how vision may be impacting things that you may not have thought vision had anything to do with. So I find that that part of it very fascinating. And I guess one of the questions I would have is when someone has either been referred to you or makes the decision that, hey, maybe I need to go see a low vision specialist, what should they come prepared to share with you? How can they best prepare for a low vision exam?
Okay, very good question. They should bring all like the magnifiers and glasses they're using. We do send out like a questionnaire of like specific things in large print that they're having problems with. So they can fill that out or have a loved one go over, the questions with them so that we kind of know what problems they're having. So I think our package, the only thing that's wrong in our package is like a low vision exam is going to take 2.5 hours. And they're like, no, it's not. That's too long. So that's one thing we have to fix on it. But I think our information package kind of lets them know what they need to kind of have to be prepared for their exam.
I have a question.
Sure.
I work with, I'm a VRT, and I see a lot of people who have diabetes and they have neuropathy in their feet.
Mhm.
So do you recommend with the vestibular testing, do you recommend that I ask them that I recommend that they go get vestibular testing? What's the first step with that? Will they go get a hearing test, or how
That's a good
does someone
question.
go
Yeah,
about
so
that?
I think like if you have a patient like that, that you should probably the best thing would either be to have them ask their, and sometimes this is hard because these doctors are busy, like a vestibular therapy screening, you kind of need a referral from like a PCP, or maybe you guys can do it, or their endocrinologist, or somebody like that. But I know, like me being an optometrist, or I should say my being, like I mean, I can send for vestibular therapy, but they're definitely going to double check, for insurance reasons, to have maybe their medical doctor cover it, or not cover it, recommend it for it to be covered with insurance.
Okay, so it's called vestibular testing.
Yeah, you could just go for like, vestibular testing. I mean, but
Mm,
remember, the ears, like dizziness is different than vertigo. And that's
mm,
something that we all need to know. Like vertigo is like true benign paroxysmal, vertigo. Like, so that's crystals in your ears that have been dislodged. So these people with vertigo that have like the crystal problem, they will literally like be sick as a dog. Like they'll tell you the day and the time that it happened. Like the world is spinning, they're vomiting, and they'll go to their ENT doctor and they'll put him in certain positions. Like I told you, I took that vestibular course. I had the Epley maneuver like done on me like 47 times. I think I had vertigo after. It was, I'm
mm,
kidding, but it was, I mean,
mhm.
there's maneuvers that get those crystals back in place so that they're not, you know, the inner ear is everything when it comes to balance. If you don't have that stuff going on, that you're going to fall down, you're going to be sick, you're going to be in bed. So we need to know the difference between dizziness and vertigo. So you guys need to know the difference with your patients. So if they've had, you can kind of probe like, oh, did you ever like go to an ENT doctor? They ever like reposition like your crystals in your ears? And they like, yeah, they did. They did do that. And like, I felt better after. Then that they had an occurrence of vertigo, and and the vertigo is completely different than dizziness. Dizziness can be caused by other uncompensated vestibulopathies, like Meniere's disease. There's tons of them that can cause, dizziness. So that would be,
Okay.
ENT determining that. And then vestibular therapy, let's say working on motion sensitivity, like the kids that always get sick in the back, in the car,
Mhm.
or like the patients after traumatic brain injury or whatever's going on. Like they look at the windshield wipers and then raining at the same time. They're like, oh my gosh, like I cannot do this right now. So what's
Mhm.
going to happen with that in vestibular therapy is going to be like adaptation. They literally will do vestibular therapy so they can get used to the movement, head movement, and movements in front of their eyes that make them sick. So I will tell you that vestibular therapy is usually not fun for people, but it gets them better.
All right. So the first step would be go see an ENT to get diagnosis if you need to go vestibular
Maybe
testing,
not. Like I would say PCP first, because the
PCP.
PCP, you're like your internist is going to be like, okay, like when you lay down in a certain, when you lie down in a certain ear, like is it your right ear or your left ear? Do you feel dizzy? And like that's going to tell you like which ear is affected, right? And
Mhm.
then they will do further testing in the ENT. So when you tell your general doctor, like, you know what, I feel way dizzy when I turn over in bed. Like that's one of the number one things that will be vertigo related. They'll
Okay.
say, and
Mhm.
then their doctors are gonna be like, oh, okay, like we're definitely sending you to an ENT. So then the
Okay.
ENT will determine, if there's a problem with the ears.
Okay. Thank you.
Mhm.
Well, this has been fascinating, Dr. Wong.
I'm sorry. So
No,
much said.
this has been great. I feel like we could have you back for 5 additional sessions. So
Anytime you need me, I'll be here.
we are definitely going to keep in touch, and definitely
Yeah.
want to say thank you for today. I think it's been really informational and hopefully a lot of good education content that people can act on. What email should people reach you at, or if they want to come over and schedule an appointment, how should they reach you?
My email is Jennifer period Wong, WONG at beaumont.org.
Thanks again, and have a great rest of your day. And it's a holiday weekend, so hopefully
Woohoo!
get a little time to enjoy it, and we'll definitely be in touch in the future.
Yeah, anytime. I like to talk.
I like the fact that you like to talk. So thank you again.